Dear colleagues, this is soft cataract done in subconj anesthesia. The patient have a IFIS syndrome. The pupil is not dilating well, so it's very important to have the important maneuvers done pretty quickly before the pupil is shutting down. I'm fashioning a nice round capsulorhexis, probably should have been a little bit larger one. Doing some hydrodelineation. Probably that hydrodelineation will make the case a little bit harder than better. A good hydrodissection is good in these cases. With the long chopper, I'm able to place at the equator of the nucleus, and I'm able to do a nice horizontal chop. The cortex, the epinucleus, the nucleus is very stuck together. It's very mushy and soft, but I'm pretty sure the crack the first crack went all the way down to the posterior plate. The second lateral chop, it's finished, so I'm starting emulsifying the quadrants. It's not basically emulsification, it's more of a aspiration, and you see the pupil coming down, and it's getting smaller and smaller by the time you stay in the eye with irrigation. It's getting even smaller than this. In the beginning of your career, should be nice to have a couple of devices to dilate the pupil. Iris hooks, Canabrava ring, B-hex ring, Gupta ring, whatever you feel like using it. It should be nice and have it ready and using. I'm pretty sure I'm able to finish up the case without pupil expanding device, but you should use one in the beginning of the career. The entire nucleus is aspirated out of the eye. I'm left with a thick epinucleus that is very sticky to the bag, and I'm trying to aspirate it as much as possible using the phaco probe. This thick epinucleus, it's taking even longer time to aspirate it if you use irrigation aspiration or an aspiration cannula. That's why I'm changing the phaco setting machine from the quadrant removal into cortical removal, and I'm trying to take little by little the thick epinucleus out as much as possible, especially in front of the phaco probe. If you're left with a small chunk of epinucleus and cortex underneath the main incision, it's fine to take it out with the irrigation aspiration probe. And if you feel safer using that from the beginning, you go ahead and do it. I'm okay with aspirating this thick epinucleus using the phaco machine. Having a larger opening, I'm able to take out more mass of the epinucleus at once, so that's why I'm preferring to use the phaco needle instead. Using the chopper to push back the iris and to visualize better the thick epinucleus in the area that I'm aspirating it, and part of it it's out. Right now I'm taking the one that is in the middle of the eye, the whole section in front of the phaco probe, it's aspirated, and using the chopper to retract the iris, I'm able to aspirate more than half of the cortex and epinucleus. And then for the last part, I'm injecting a little bit the viscoelastic to push back the iris and to try to dilate a little bit more the pupil. But as soon as aspiration starts, the pupil will come down again, of course. So I'm switching now to the aspiration cannula on a side port and using the irrigation through the AC maintainer in the big paracentesis on main incision. I'm able to finish up the cortical removal. And using the AutoSert, I'm injecting under viscoelastic the IOL inside the bag. The leading haptic is unfolding inside the bag. Push back the optic, and then using the chopper I'm able to place the trailing haptic again inside the bag, centrate the IOL, washing out any viscoelastic, and that's the end of the case. Thank you for your attention.